Hey everybody, this is Dr. Danesh. And welcome to the 50 Shades show. I gotta flash the screen up here, 50 Shades of Pain. I was supposed to talk about neuropathic pain today, but I have to deviate our course because today the landmark case in Oklahoma against Johnson & Johnson, the ruling came out, and the court sided with Oklahoma State, awarding them $572 million as a result of Johnson & Johnson's role in the opioid epidemic. So the reason I wanted to talk about that was because I actually was an expert witness in that case, and I haven't been able to talk about it because of just the ongoing case, but it's been something that I have been thinking about tremendously over the course of the past year. I was very grateful to be involved and to be asked to be the state's expert witness when it comes to managing pain. It was quite an honor, but beyond that, it was eye-opening for me as well. I mean, I knew of some of the problematic activities that took place that evolved the opioid epidemic, but I didn't know the full extent of it. And I think that as people become more aware of the issues that were uncovered in this case, it would be helpful for us to understand how this problem developed, how healthcare allowed this to evolve before we actually started taking action in terms of curbing the damage that was as a result. So the things that I testified around was the role of opioids in managing pain, and the role that the opioid manufacturers had in misaligning healthcare's approach to managing pain. Primarily, they deviated from what was evolving in the 1980s and 90s of understanding the mechanics and the neurological foundation of pain, and rather promoted this one-size-fits-all solution when it comes to opioids in treating pain issues. So originally, opioids were intended for dire situations, like if you have surgery or if you're dealing with cancer. But along the way of promoting its sales, a lot of opioid manufacturers started to promote opioids as a mainstay for just general everyday aches and pains. Now, what I testified about was the problems and how that was not founded in science, that it actually is a strategy that promotes increasing levels of pain. Primarily, opioids will give a temporary sense of relief, but I kind of explain it as there are two parts to your brain, one that recognizes pain and the other part that reacts to it, essentially. So one part of the brain acknowledges that something is causing pain. The other part of the brain says, oh, I should do something about it. And opioids only work at that second side, the part that your brain cares about pain. So it doesn't take away the pain, it just makes you care less about it. The problem with that is the part of your brain that actually recognizes or acknowledges the presence of pain needs feedback from the side that cares about the reaction. And if it doesn't get that feedback, then progressively it thinks that it needs to just turn up the volume or make the volume of that pain signal louder and louder so that it can get that acknowledgement or response from the other side of the brain. So as time goes on, what's evolving is that these two parts of the brain are in conflict, and people need ever increasing doses of opioids in order to keep the part of the brain that doesn't really care not caring. So nothing is being done to actually fix the damage. Nothing is being done to actually treat the cause of pain. And you're not even turning off the pain signals in the brain. You're just simply making the brain less attentive to it. So it is indeed going to increase in its sensitivity over time. The other downside is that when you take pain medications, it might give you a temporary relief, but there's a rebound effect to it because of that whole increased sensitivity or that hypersensitivity. So as time goes on, people become not only more sensitive to the original pain, they also become more sensitive to pain in general. All along the side, the condition that's causing the pain is just getting worse. It's just increasing due to neglect. So a lot of the things that we use to actually treat pain fell by the wayside, became less prioritized because the message of pain medication as being the one-size-fits-all solution to all pain issues became so prominent that clinicians, the whole science of how to address pain was lost. So in the testimony, in the Oklahoma opioid trial, that was essentially my testimony, that this misalignment of how we treat pain evolved directly as a result of pharmaceutical marketing and mismanagement of opioid marketing. A lot of the statements that have come out of that, a lot of the myths that are now common beliefs, are derivative of opioid marketing, which was a bastardization or manipulation of the science. So for instance, they talk about, if you don't take your pain medicine at the right time, if you fall behind on managing your pain, then it's hard to catch up. Well, the foundation of that was based off of regional anesthetic studies, which numbed nerves prior to those nerves sending their signals to the spinal cord. So before the pain signal even makes its way to the spine, if you numb that nerve, then the signal at the spine level is never heard. So the spinal cord never sees that pain signal. Well, what happens at the spinal cord is that pain signals that come in actually ramp up the spinal cord sensitivity to pain. So if you, for instance, strike your thumb with a hammer, that pain signal is really loud, and so the spinal cord becomes really, really aware of the pain that evokes. As a result, it will sensitize every other nerve that's sending a signal into the area. So it goes into a red alert state, so that even nerves that feel touch or movement are sensitized to pain. That's why, if you notice, whenever if you get your hand caught in a door, or if you stub your toe, or you strike your thumb with a hammer, it's actually hard to move your thumb, not because there's mechanical damage, but because that reflex in the spinal cord has sensitized everything, and your pain is more the dominant signal that your spinal cord responds to, rather than movement, rather than touch. So if you're able to block that pain before the spinal cord sees it, then you can stay ahead of pain. But once it's there, opioids are not going to have the same effect. Opioids work in the opposite direction. They work from the brain down rather than the nervous system up. So that staying ahead of the pain is just a myth. Another myth that was conveyed by pharmaceutical marketing is that you can't get addicted to opioids if you're taking it as prescribed. Well, the question is what does as prescribed mean, and who's the prescriber? Our medical education system was grossly manipulated by a lot of pharmaceutical marketing. So one of the things that the lawyers defending Johnson & Johnson brought up against me was that when I was a resident in anesthesia, I co-wrote a chapter in a textbook, and I'm looking to see if I have the textbook here. I think I do, actually. Yeah, it's this book right here. So I was one of the co-authors of a chapter on pain management in that book. And in that book, I wrote about some of the things that I now decry as myths within the field of pain management. Concepts like pseudo addiction, where they say that if a patient is showing signs of addiction, it may not be real addiction. It may be what's called pseudo addiction, which is just undertreated pain. Well, if you understand the concept of how opioids work, that doesn't make any sense that you're undertreating pain with insufficient opioids, because we know that the body will adapt to opioids. So if a patient is showing concerning signs that they're losing control of how they manage their pain, of how they take their pain medications, that's not necessarily a sign of what pseudo addiction. It could be a sign of opioid use disorder or even addiction, which are two different things. And we can talk about that in some point down the road if anybody's interested. But I actually wrote about pseudo addiction and advocated it in the textbook. But I know now that it's not true. It's actually false, because there's no scientific foundation for pseudo addiction, and it just creates this nebulous environment where patients who are really adapting poorly to opioid exposure are at increased risk for opioid use disorder or addiction. It essentially gives a blank check to ignore all of those patients. So I'm getting some messages about the law case, about the settlement or the awarding. So I'll come back to that. But going back to the whole premise of pseudo addiction and how the lawyers were trying to say, well, look, even you advocated for some of these concepts that you now say are myths. And I agreed. I said, yes, I did. But it's just to show how deeply influential pharmaceutical marketing was in even the highest bastions of healthcare. I went to school at Johns Hopkins, which I still deem as one of the best medical education in the country. And I value my attendings tremendously. I have tremendous respect for them and what they taught me. But the truth is that even within our esteemed institutions, there was pharmaceutical marketing influences that changed how we prescribed medications, how we treated pain. The lawyer thought that he could catch me in that statement and say, well, why are you even putting this on your resume if it's not something you really still advocate? And the reason is that I think that those of us who have made mistakes need to atone to them. And yes, there were mistakes made in healthcare. There were things that we did not pay attention to enough that helped evolve this epidemic. And now that there's greater awareness of how problematic that was, it's important for everyone to take account of their own personal responsibilities and work towards correcting this. So messages that I got coming in from different friends is that the award was not enough. And I can definitely, I feel that, I agree, because the cost of this epidemic is far, far greater. Even 570 million from Johnson & Johnson, 280 million from Purdue, 80 million from Teva Pharmaceuticals. It sounds like a lot of money and a lot of resources, but it truly isn't. They were going for multi-billion-dollar settlement because after all, the revenue generated from opioids was not inconsequential, and the cost that it's going to take to clean this up is going to be very significant. I mean, we're already spending that amount of money, if not more, on just treating addiction, and addiction is not the only problem that has resulted off of opioid over-reliance and opioid overuse. I see patients on a daily basis who have lost hope, who have been burnt out by healthcare because opioids were propped up as the cure-all for whatever ails them, whatever pain they're dealing with. And alongside of that, all of the things that do actually help, like physical therapy, like proper diagnosis, like good nutrition, lifestyle modification, simply understanding what's going on in the body, all of those things were put on the wayside in favor of just simply prescribing opioids and sending the patients on a month-to-month basis revolving door where they keep coming back for a refill. There are very few conditions that we're this complacent around. We don't say somebody was diagnosed with cancer and then just treat every single cancer case the same. We figure out what the cancer is. We figure out how far it's spread, and then we talk about all of the different modalities like chemotherapy, radiation, surgery, all of these different modalities to treat cancer. But when it comes to pain, we're not nearly that robust. We say, oh, you've got back pain, therefore here's some pain medications. We'll wait until it gets bad enough to warrant surgery, and then we'll send you off to a surgeon. And that just doesn't make sense. It defies the whole rationale of medicine, which is proper diagnosis in order to define proper treatments. So the cost to not only treat the problem of addiction that we now have as a result of opioid overpromotion, the cost of not addiction, but opioid use disorder, people who have become dependent on taking pain medications, not because they're addicted, but because their physiologic system has adapted to the presence of opioids. And so they're now dependent on taking it just for normal everyday functioning. And I tell my patients, if you'd never been started on pain medications versus now, I'm not sure how different your pain would have been. And if in the early days when your pain started, if we actually figured out what was wrong and fixed it, it may not have evolved to this point. But with the over-reliance and over-promotion of opioids, a lot of that science went away. When I came back from fellowship and I joined my parents' practice, I went through their bookshelf and started looking at all the books that they had, talking about like the biomechanics of the spine, the ligamentous structure of the spine, how joints move and how arthritis develops as a result of misalignment or maladaptive motion. All of those textbooks were new to me, even though they were written in the 70s and 80s. And that should not have been the case. I should have had that exposure in my medical training where we talk about the mechanics of pain, the neurological changes that happen with chronic pain, the neurological changes that happen with opioid exposure. And none of that was really covered during my training. It was all things that I had to study and learn after training. So when they talk about, $500 million settlement for, I'm blanking on the word for a trial that ends successfully in the plaintiff's favor, but $500 million case against Johnson & Johnson, whether that's sufficient to cover the costs, we're not just talking about the costs of treating addiction, of treating opioid use disorder, of treating patients who have pain issues but have not been properly diagnosed or treated. We're also talking about changing the fabric of healthcare, changing the way that medical education approaches pain issues, changing the way that we think about surgery as a necessity, the way we think about physical therapy. All of these things need to change. I had a patient come in today who said, who has a muscular problem causing his back pain, for which physical therapy would be the first line treatment. And I asked him if he had started physical therapy, and he said, no, my doctor said that doesn't work. and wanted to write me some pain medications, and so he came to me instead. Well, that is a fundamental problem within healthcare, that if physicians, our first-line physicians, have the perspective that physical therapy is fluff and that it's either pills or surgery, that is the problem. And the cost of changing that is tremendous. I know, because I've done lectures, I've taught clinicians about opioids, about pain, managing pain, about how we can prevent the transition of acute pain into chronic pain. And in spite of that, the questions that I get, the feedback I get, the conversations that I have, it reflects a very, very slow process of really implementing change within healthcare. And so, while I think it's great that Oklahoma State won the lawsuit and set a precedence, an important precedence, I'm concerned that the scope of correcting, the scope of rectifying this problem is not quite being appreciated of how sizable it is, because it's not just going to take undoing some of the damage of mistreating or undertreating patients with chronic pain issues, or neglecting patients with acute pain issues and preventing them from becoming chronic pain issues. We're not just dealing with the costs of that, we're also dealing with the cost of changing healthcare, of changing the approach within healthcare. And I'd love people's ideas on how to do that. In fact, if I can ask for anything, anybody that watches this video, if I can ask for one thing, it would be to give us some ideas of how we can change the fabric of managing pain, both from a healthcare perspective as well as from the layperson's perspective. Like for patients out there who have been exposed to our treatment processes, who have been exposed to the HEAL methodology of hearing the message that your body's trying to convey with pain, envisioning what life is meant like, essentially reestablishing goals that create a sense of identity, not being defined by your pain. How to A, alleviate the symptoms, and L, leverage healing. I'd love to hear from patients who have been through that HEAL methodology on how we can increase the scope of that message, of how we can get that message out there to people so that other people understand that it's not just about symptom management, it's not just about numbing pain problems with opioids and just waiting for it to get to the point where surgery is an unavoidable treatment option, but rather being proactive about treating conditions before they get to the point of complete neglect and breakage. I would love to hear your ideas for that. So anyways, again, today's episode of 50 Shades is a deviation from what I was originally planning, which was neuropathic pain. But I think that this landmark case outcome is important to discuss and important to evaluate the implications and what needs to be done. I have to commend the lawyers I worked with. They were incredibly passionate. These guys worked at the lawyers at Nix Patterson. They worked tirelessly for months, and the brief period that I was there working with them, they've been running a marathon for literally months, and I think they deserve the credit and kudos for having built such a strong case around Johnson & Johnson. I would encourage you guys to go and look at some of the video testimonials, particularly of the expert witnesses, the ones that I met, the ones that I've known for years, Andrew Kolodny, Mel Pohl. These are some brilliant clinicians who who have really put their neck on the line, because it was not easy standing up against these lawyers, and it's not easy to stand up against the scrutiny that comes from putting your opinion out there as an expert, because there's always ways that you can argue against an opinion, but it's a matter of figuring out where the incentives lie and where the valid studies lie, and understanding the studies in a level at a level of detail enough to know when we're being duped with bad information or misinterpretation of studies. So what I'd like to see moving forward, the pharmaceuticals kind of used 4 pillars to promote opioid over-reliance. They misinterpreted the science. They recruited key opinion leaders to give their opinions on the use of opioids, and to try to create an environment in which it seemed like it was safer than it actually was. They invalidated the people that were saying this is something we need to be concerned about, that we need to maybe look at the science more deeply, and they vilified patients who were adversely affected by this over promotion of opioids. The patients that have suffered from addiction, the patients who have overdosed. A lot of the statements that it's the addicts that are ruining it for those of us who actually need pain medication is a really dehumanizing statement that does nothing to help either the patient with addiction nor the patient who's dealing with a pain problem that really isn't being addressed. So it's going to take a lot of time and a lot of effort to undo a lot of these myths, to promote the proper messaging around how to manage pain, to reinvigorate hope among patients who have been dealing with pain issues, whether it's something that's been deemed as this degenerative process that nothing can be done about, things like disc disease or lumbar spinal stenosis or osteoarthritis. It's one of our goals to reinvigorate the hope that people can live functional, happy, and comfortable lives without over-reliance on opioids. And in fact, they'll have a better chance of overcoming their condition or improving their condition without this heavy-duty over-reliance on opioids. I know it's a hard message to convey, and it's a hard one to understand for people who have found opioids helpful, but especially if you can talk to some of the patients that we've seen who we manage with non-daily dosing of opioids, it works, but it takes a leap of faith, because that transition period between maintaining daily opioids to going to non-daily dosing is a difficult transition. I'd love to hear opinions about the Johnson & Johnson Oklahoma trial. I'd be happy to talk in more detail about it. I'm drafting an op-ed about the outcome of that case, so keep your eye out for it. Hopefully it'll come out, and we'll have a better long-term conversation around this topic and what needs to happen going forward to rectify healthcare's approach to pain and to temper some of the damage that has already been done. Anyways, thank you again. If you haven't read up on these cases, I highly encourage it. And if you have any questions about it, feel free to send us a message on Facebook or just get in touch with us, because this is a conversation that needs to be had, and it needs to be had across all of society, both healthcare and individual people. Thank you, everyone.